What I'm going to talk to you about today is the access component of this conference and how the organization that I work in, the Center to Advance Palliative Care, and the one my colleague Sean Morrison, who was mentioned in the We Don't Carry That paper, who leads the National Palliative Care Research Center, how our two organizations coordinate in an attempt to improve access to palliative care. So what we've seen in the States is a dramatic increase in the number of clinical palliative care programs in the last 10 to 15 years, improving public and professional awareness. Palliative medicine is now a distinct medical, nursing, social work, and chaplaincy specialty with board certification in the States. We have somewhat better professional training and educational efforts, undergraduate and postgraduate, increasing research evidence on the benefits and the outcomes of palliative care, and some major quality and policy initiatives. And how did that happen in the last 14 years? It began with evidence. It began with science, a clear body of research that demonstrated improved clinical outcomes, the association of palliative care with what patients and families say they want, and not least, an abundant, increasingly convincing body of evidence that palliative care, because it meets people's needs, actually markedly reduces healthcare utilization. Through my organization and others, we've provided very practical, granular technical assistance to hospitals, other institutions, and educators to try to translate this research into actual practice at the bedside, focused attention to education, and very targeted and strategic media outreach to both professional and public audiences. So I'm going to talk first about the NPCRC, the National Palliative Care Research Center, supported entirely by philanthropy, located at our medical school, the Icahn School of Medicine at Mount Sinai, directed by Sean. The audience for this organization is academic, research institutions, researchers, and policymakers. The focus is development of an evidence base as well as an investment in research capacity and infrastructure. The products of this organization are pilot and exploratory grants for mid-career investigators, career development awards for people very early in their career, technical assistance, and support for people trying to do very complex research in palliative care. The organization I lead, the Center to Advance Palliative Care, also 100% supported by private sector philanthropy. We are going to become a membership organization in the first quarter of 2015 in order to reduce our dependency on philanthropy. In order to be able to actually bring technical assistance to scale, we are going to have other sources of income other than private sector contributions. Our audience is hospitals, health systems, other healthcare organizations, payers, clinicians, policymakers, and I don't know why I left this out, the public. Our focus is on dissemination and implementation of the evidence base to try to reduce that gap between bringing evidence into practice. And our products are practical tools, training, technical assistance to try to basically reduce the opportunity costs, make it easier for our colleagues across the country and in a range of healthcare settings to deliver palliative care to their own patients. Our vision and goals are shared, and it is that by 2020, all people with serious illness and their families will have access to quality palliative care throughout the disease course and across all care settings in the U.S. And specifically, that translates into 1, all patients and families will know what palliative care is and request it in the setting of serious illness. And interestingly, you'll see we have an identical number that was just presented to you of people who actually have no idea what it is. All medical professionals, and by medical I mean medical, nursing, social service, spiritual care, will have the knowledge and skills to provide high-quality palliative care. And there I'm not focusing on specialists, but on generalists. And thirdly, all hospitals, home care organizations, nursing homes, physician office practices, cancer centers, dialysis units will be equipped to deliver and support quality palliative care. So everything that we do falls into one of these categories, one of these three categories. Outreach to the public, outreach to clinicians, improving clinician skills, and trying to encourage all organizations responsible for delivering health care to deliver palliative care as well. So here are the principles that guide our work, and the first is thinking strategically. And this is a slide of a very famous Canadian hockey player, Wayne Gretzky, who was quoted as saying, "I skate to where the puck is going to be, not where it has been." So thinking a lot about the points that were made earlier. Where are the population needs going to be? Where is the population that needs palliative care? They're not mostly in hospitals, right? They're mostly outside of hospitals. The second guiding principle was a very hard thing for me to learn, and it is that we are not the audience. Many people in palliative care got into it because we saw very bad deaths in our training, in our families, in our communities, and we wanted to prevent that. We wanted to improve that process. That's what motivates us. We think that that's what motivates everybody else too. However, there's lots of evidence that that is not the case, and this is a quote from Tom Finucane at Johns Hopkins University, that people have an abiding desire not to be dead. Homer said, "Better to flee from death than feel its grip." Shakespeare said, "The weariest and most loathed worldly life that age, ache, penury, and imprisonment can lay on nature is a paradise to what we fear of death." And Woody Allen said, "I don't want to achieve immortality through my work. I'd rather achieve it by not dying." So we have worked towards a fundamental shift in message away from improving care of the dying and to improving quality of life for those living with serious illness. And I promise you, patients and families are much more responsive to the latter than to the former. So the third guiding principle is that the responsibility of a researcher begins with the journal publication but does not end there. And the research infrastructure in the United States really has failed to go beyond publication to implementation and application of findings to actually improve care at the bedside. Clearly, policymakers and the public do not read our medical journals. Creating change requires audience-specific messaging, effective use of the media, and technical assistance. U.S. Admiral Hyman Rickover said, "Good ideas are not adopted automatically, they must be driven into practice." So we think about this as a circle with top-down and bottom-up strategies. The bottom-up strategies are promoting and developing the palliative care evidence base and increasing access to quality palliative care through training, research, and technical assistance. The top-down strategies have to do with policy. How do we pay? How do we measure? How do we accredit? How do we regulate the things that policymakers can do to make palliative care standard of practice and not nice to have or optional to have? So on the research side, well-documented need for better evidence in palliative care, and lots of national and international reports calling for more evidence in palliative care. The barriers, obviously, lack of funding, lack of a pipeline of investigators, lack of mentors for new investigators, and a very small research community. One of the interesting things that has happened in the last few years is closer collaboration between the Ireland, UK, and US research community, which only reinforces to me what a small little tribe we are. NPCRC does career development awards for young people, pilot and exploratory grants for middle-aged people who want to compete for federal research money, and consultancy and infrastructure support, tools and mentoring. We have an annual research retreat. We have a clearinghouse for research funding and publications in palliative care, and a recommended instrument repository so that people use well-validated measurement tools, and a number of organizational partnerships. So for example, the American Cancer Society, as a result of NPCRC's work, now funds $5 million per year of palliative care research in cancer. And we're trying to get the same thing done through the Alzheimer's Association and the American Heart Association and the American Lung Association through partnerships. The outcomes are actually quite striking of the NPCRC. Up to 2013 had funded 27 career development awards at the cost of $4.5 million, which has translated into $16.5 million in additional research funding, nearly fourfold return on investment, and 92% of our career development awardees went on to successfully compete for National Institute of Health funding in the most competitive research environment in my lifetime. It is the pay level has dropped to about the 5th percentile at the NIH now. Similarly, the pilot grant awards, 17 awards to 12 institutions at a cost of $2 million, that translated into nearly $20 million in additional research funding with a 9.5-fold return on investment. 100% of these awardees successfully competed for NIH our awards, our level awards, incredibly difficult to get during this time frame. Now, clearly we're this successful because we are extremely selective in who gets these grants. But the point is to invest in those who are likely to succeed, because that is what the field needs. And these investigators have also published more than 500 research articles in the last 5 years. So this is the growth of the evidence base. We've also convened a State of the Science meeting with the National Institute on Aging and got them to release 2 RFAs for geriatric palliative care research, so that will be a federal funding source. And we're about to meet with the National Cancer Institute, which is the 800-pound gorilla at the NIH, to do the same. So a series of papers establishing the research priorities, and then NCI establishing a call for proposals, so that we're not funding it, they are, but we're driving the research priorities and the allocation of money. So over to the Center to Advance Palliative Care. We've talked about the delays in translating knowledge into practice, the lack of standardized approach. Our vision, again, is that all people will have access to quality palliative care, and our 2 approaches are, first, to train generalist clinicians, not specialists, in core palliative care knowledge and skills. There will never be enough of us specialists. In 10 lifetimes, there will not be enough of us to meet the needs of the populations that you just heard whose needs are not being met. We have got to improve the skill set of frontline clinicians in every setting. And we've got to expand palliative care beyond hospitals, because that's not where most illness takes place. Most illness takes place at home and in communities. So we're working on 2 new curricular streams or strands. First is aimed at palliative care specialists and helping them expand palliative care beyond either hospice or hospital to other settings. And the second strand is all clinicians, and the core skills are pain and symptom management and communication that we're focusing on. And those are the courses we'll release in the first quarter of 2015. And we're working with a really high-tech, very modern instructional design firm called WeeGee. You can look them up online, WEEJEE. And basically their thesis is no boring, nothing should be boring. So we're hoping that people, and the other great thing about it is that it will work on your iPhone, it will work on your iPad, it will work on your computer. You can do it while waiting for the train, sitting on the bus, and all of these courses will be linked to continuing education credits, which all professionals have to do every year in order to retain their license. So the courses will not only be linked to credits that people have to get, so it's an incentive, but they will also be linked to metrics that the government requires of nursing homes, home care agencies, hospitals, and physician practices. Because increasingly, I don't know about here, but in the States, your ability to get paid is linked to your performance on quality measures. So these courses are directly linked to improving behavior on those quality measures. So we will not only have these e-learning, which are one person and a screen, but we will also use the internet to go to scale on things like virtual office hours. So for example, we may have Irene Higginson do virtual office hours one Thursday a month at 4 p.m. UK time, 11 a.m. US time, and anyone in the world can sign up and call in for an hour to talk to Irene. Or me, or other international and national leaders, basically exploiting the power of the internet to connect people. We have 9 centers of excellence for team training, one of which is led by my colleague Steve Pantalette, who just walked in at UC San Francisco. Those leadership centers have trained over 1,300 teams around the country and nearly 5,000 individuals in the last 10 years. And at 2 years, they have nearly an 80% success rate, that their learners have gone home and successfully established, launched, and sustained a palliative care program. So it's a very effective intervention. We have a national annual seminar. We have a forum for people talking to each other. We have more than 7,000 users, and our website is chock full of tools and technical assistance. We're also funded to do a social media public awareness campaign and have developed a public-facing microsite called getpalliativecare.org, which defines palliative care not as end-of-life care, helps people think about what the benefits might be if they had emphysema, heart failure, dementia, childhood chronic illnesses, as well as cancer. But the very important tool here is a national registry. So you can put your zip code in or your city in, and a drop-down list of all the palliative care programs in your neighborhood comes up with the phone numbers. So we're trying to drive, people don't know what's in their neighborhood, so we're trying to drive connection between patients and families and palliative care teams. So I'm going to give you just a couple of examples. Example 1 is the top-down strategy, building demand for palliative care. And one of the ways in which we approached this was to examine state-by-state variation in access to palliative care, examine access to clinical training in palliative care, and identify predictive factors for access to palliative care. And this was a collaboration between our 2 organizations and the American Hospital Association, which conducts an annual survey every year. So they gave us their data. This is the publication, Variability in Access to Hospital Palliative Care in the United States. And what we found is this steady growth in access to palliative care between 2000 and 2014. And these are the products. So this is what 𝐃𝐎𝐍𝐀 did with these data. We gave awards to all the states that got an A, states that had between 80 and 100% of their hospitals reporting a palliative care team. We went to the Senate. We brought a framed certificate that, your state gets an A. We had photos taken with the senator that were then published in the local newspaper. And the result was that all the states that didn't get an A got really upset. Because we basically showed in this report card, you could see that states in the south of the United States, again, the poor, high minority areas, have the least access to hospital palliative care. And in fact, the only F states were in the south. The F and D states were largely in the south. And what we've seen, having done 2 of these report cards, is a marked improvement between 2008 and 2011, and we're doing the next one in 2014. And public embarrassment is quite effective. We call it the naming and shaming approach. And interestingly, we have focused a tremendous amount of technical assistance in the South because of these data. So we added a leadership center in Birmingham, Alabama, to make it easier for hospitals in the South to get training. And we have held all of our national seminars in the South since these data came out. And we got a ton of media coverage of this because local newspapers love to cover things about their state. Reached more than 10 million people with the media campaign around this. So example 2 is the bottom-up strategy, which is creating evidence to drive more investment in palliative care, and the strategy was to develop the business case. So the research objectives were to identify and quantify the cost savings, applying propensity score and instrumental variable methods, and examining cost savings across. In the states, we have multiple payers. We have Medicare for old people, Medicaid for poor people, commercial payers for some employed people, and the Veterans Administration. So these were the 2 studies that came from this, the first in the Archives of Internal Medicine, the second in Health Affairs. The first was all payers. The second paper was Medicaid only, which is the insurance program for the poor. And the product was this one. Very slick, beautiful, lots of color, that basically was mailed to every CEO, CFO, COO, Chief Medical Officer, Chief Nursing Officer in the United States. With very few words, lots of white space, because they have short attention spans and they don't read research. So you see what on the right it said, 2.5 million savings for the average academic medical center, 1.3 million for a 300-bed community hospital. I wish I could tell you that the growth in hospital palliative care in the last 10 years is because people recognize the need for improved quality. This slide is the reason for the growth in hospital palliative care in the United States. Basically, we convinced hospitals they could not afford not to do it. And that drove behavior change. Now, that would not drive behavior change in the public, right? They're not motivated by saving hospitals money. So your message has to fit your audience, right? This was not disseminated to the press or the public. This was disseminated only to the C-suite of hospitals. Also got some press, fortunately or unfortunately. One of the headlines that was okay was better care of sickest patients can actually save hospitals money, says biggest study of its kind. Politico, which is the most widely read policy rag in Washington, D.C., headline, palliative care adds up. We were really worried, actually, about this publicity and having the public link cost savings to palliative care. So the outcomes of this, among them were the Joint Commission, which accredits the majority of hospitals in the United States, developed a palliative care certification to recognize hospitals with high quality palliative care, something I had been fighting for 10 years. Didn't happen until after this. And New York State passed a law based on that Medicaid study requiring that all healthcare organizations that receive Medicaid reimbursement, which is all of them, provide access to palliative care to patients who could benefit. So it was a very direct translation of research, not only into practice, but also into policy. And we did that research knowing that it was policy relevant. That's why we did the research in the first place. And then last example, supportive legislation. Our goal was to create funding for research and public education by driving public demand. There are 2 ways to change policy in the United States. Embarrassingly, the most powerful way is to spend money on the campaigns of your elected representatives. And if you're reading anything about what goes on in the states, our government is almost a wholly owned subsidiary of special interests at this point. But those of us in palliative care do not have money. The one thing we do have is public demand if we drive it. So public demand is also a key driver of policymaker behavior because legislators need votes. So if you organize interests, just as with ACT UP with AIDS in the United States, that was unbelievably effective, and not because of money, but because of really good strategic advocacy. We have failed to do that in palliative care, in part because the patients are too sick and the families are too exhausted. But what we did was public opinion research with over 800 likely voters, market research on wording, And we used a very well-respected Republican polling firm in Washington quite deliberately so that the message would be acceptable. And just as you just heard, about 80% had no idea what palliative care was. It's interesting how similar it is between our two countries. Yeah, well, I would have expected to be better here because of Cicely Saunders. But again, we are not the audience. So once people were presented a definition of palliative care that was not focused on death and dying, over 90% said they wanted it. That was the really critical finding for policymakers. Over 90% wanting something, you never get public opinion research at that level. That's very persuasive to policymakers. So this is the definition that came from this research. Basically, we gave people a bunch of elements or descriptors of palliative care and asked them to rank those that were most important to them. And nowhere was terminal care, good care of the dying, didn't get ranked. These are the top ranked characteristics. Relief of symptoms, pain, and stress, improves quality of life for patient and family, provided by a team, they liked that for some reason, who works with a patient's other doctors to provide an added layer of support. It's not the consolation prize. It's not what we do when there's nothing more that can be done. It is concurrent with regular medical care, appropriate any age, any stage, and can be provided at the same time as curative or life-prolonging treatment. We have taken that definition in concert with the American Cancer Society and created a public awareness campaign. This is one of the ads. You can see the word cancer in black Arial font gets switched to dancer. So this person is not a cancer diagnosis, this person is a dancer, and the definition in smaller print is there using the language that we identified in the public opinion research. The second ad in this series is a mother. The word chemotherapy in black Arial font, the CHE crossed out, the APY crossed out, mother. And the third ad is a child on a swing in a playground, and the black Arial font says stage 4, and the crayon crosses out the ST. Very powerful. I mean, now clearly this was a very expensive Madison Avenue advertising firm that developed this. Don't try this at home. I mean, people do this for a living. And we need professional help when we do public awareness campaigns because we are not the audience. So these are the barriers: workforce, evidence, access, public education, and professional misconceptions. We need more workforce, we need more research, we need better access to palliative care, and the way we're doing that is by focusing both on academic medical centers, large hospitals. I'm trying to get the Joint Commission to require palliative care as a condition of accreditation. If you're not accredited in the United States, you can't get paid. So accreditation is a very powerful lever. Right now, we have an optional certification. So if we drive a lot of participation in a certification, we may make the Joint Commission comfortable enough to actually require this. We need more public and professional awareness. Again, message is living well with disease and promoting quality of life. Here are the other ad that I mentioned to you. And based on these ads have run repeatedly in the Washington, D.C. Policymaker literature like Politico and The Hill, and they are linked to legislation that drives support for research and training in palliative care. So say to policymakers, look, the public wants this. Support these bills. And actually, it's been quite effective. We have hundreds of co-signers on these two bills on both sides of the aisle. And thank you very much.